So we're thinking about intracranial hypertension, raised intracranial pressure. And if the patient's conscious, they'll complain of some symptoms. And any time that patient has a blow to the head, it's not surprising they get a headache. The pain arising largely from the blood vessels and probably from the meninges as well, actually. They can become nauseated and there can be vomiting. There can be drowsiness and confusion, disorientation. And these patients can be very agitated. It must be awful having a bad head injury because the agitation the patients suffer is often quite extreme, and you might know yourself if you've been agitated because you've had a fever or something. It's a very unpleasant feeling. Seizures, well, fitting can occur anytime there is insult to the central nervous system. So it's always worth keeping an eye out for seizures. You could have put that into signs, actually. Would have fitted in either places. Neck stiffness and back pain. These can be caused by involvement of the meninges. Back pain and neck stiffness can mean meningeal involvement as a complication of the intracranial hypertension. Signs, of course, are things that you see about the patient, and the classic one that we observe for is reduced levels of consciousness. And we measure levels of consciousness with the Glasgow Coma Scale. So Glasgow Coma Scale will decrease with raises in intracranial pressure. And if the intracranial pressure goes over 40 millimetres of mercury, we can expect substantial decreases in the level of consciousness, substantial falls in the Glasgow Coma Scale score, going down from a normal of 15 to much lower values. Also, there can be third nerve compression. The third nerve is the oculomotor nerve that controls the pupils. So the pupils, first of all, will respond to light sluggishly, then will not respond to light and will become dilated. Eventually, the pupil on one side can become fixed and dilated. And there's something called the Cushing's reflex triad. Cushing was an American neurosurgeon, and he noticed that patients who had severe raised intracranial pressure, they had three symptoms. First of all, they had bradycardia, they had hypertension, and it was a wide pulse pressure, a very big gap between the systolic and the diastolic blood pressure. So the systolic blood pressure would rise very high without such a large proportional rise in the diastolic blood pressure. And also there can be irregular respirations. But I want to tell you something that's very important now that a lot of people looking after patients with head injuries often don't realise. And that is the order in which these signs will present. The first one to present will be the reduction in the Glasgow Coma Scale. After that, there will be loss of the pupillary reflexes, and a pupil on one side can become fixed and dilated. And of course, you might remember that the pupil that becomes fixed and dilated is on the same side as the space-occupying lesion. The oculomotor nerve is compressed. The oculomotor nerve is compressed underneath the space-occupying lesion. That stops it from working. That stops it from constricting the pupil. But that will happen after there is a decrease in Glasgow Coma Scale. And if someone has a fixed and dilated pupil, that person is already in a highly life-threatening situation. This is a serious, serious surgical emergency. So don't think that because your patient's pupils are reacting normally, this patient's absolutely fine. This is a late feature, it's a very serious feature. What we need to look for first is any reduction in the Glasgow Coma Scale, because that will happen first. And hopefully we detect the raised intracranial pressure before the oculomotor nerve is compressed. Ideally, we prevent it. If the oculomotor nerve is compressed and there's a fixed dilated pupil, that patient is already very ill. And the Cushing's reflex, the high systolic blood pressure, the bradycardia and the wide pulse pressure are all very, very late features. These are almost what you call pre-coning features. That basically they mean the patient could die at any moment. They are very late, very serious features, as is the irregular respiration. So don't think that the patient's pulse is okay, therefore the patient's okay. Don't think that because the patient's blood pressure is normal, this patient is fine. Don't think that because the pupils are reacting normally, this patient's fine. These are late features. Look for the reduction in Glasgow Coma Scale. Then you'll get the alterations in the pupillary reflex and the fixed dilated pupils, and then you'll get the Cushing's triad. But the Cushing's triad is almost a prelude to the death of that patient. So clinically, it's not particularly useful. The thing to look for is the reduction in the Glasgow Coma Scale. Be vigilant about that. And remember, a reduction of 1 in the Glasgow Coma Scale is clinically significant and must be reported and must be explained. Now, this graph shows what happens as intracranial pressure starts to rise. Now, if there's a space-occupying lesion, that will get bigger, and the space-occupying lesion will start taking up more space. So if we imagine the situation here where we have the dura surrounding the brain, and as you know, it goes down the spinal cord as well, forming the dural sac. Now, if there's a space-occupying lesion which is expanding in here, it's going to take up progressively more and more space. But as this takes up more and more space, there is not going to be a significant increase in intracranial pressure. Therefore, as this takes up more and more space, because there's not a significant increase in intracranial pressure, there's not going to be a significant reduction in Glasgow Coma Scale. And that means we can't detect this unless we scan this patient. Because what happens is, as the space-occupying lesion increases in size, this actually displaces cerebrospinal fluid from the cerebral part of the cerebrospinal fluid, and it pushes it down the way into the spinal sac, the dural sac in the spinal cord. So what happens is that the dural sac in the spinal cord area actually blows out and gets bigger, because the dura mater is fairly thick and tough around about the brain, but that same dura mater, although it's continuous, is actually much thinner down here in the spinal regions. So you get displacement of cerebrospinal fluid from the cerebral area down into the spinal area. And that compensates. So there's compensation for an expanding space-occupying lesion. And because of the displacement of cerebrospinal fluid, we don't get the increase in intracranial pressure. We might get some increase, but then what happens all of a sudden is, can you see here that as the volume of the space-occupying lesion increases, all of a sudden the intracranial pressure, which has only been increasing very gradually here, all of a sudden starts scooting up and we get massive increases in intracranial pressure. And the reason for this is that the cerebrospinal fluid is displaced downwards, filling up the dural sac, but then it fills up so far and won't fill anymore. And all of a sudden, the dural sac stops expanding. That means there can be no more downward displacement of cerebrospinal fluid into the dural sac to compensate for the growth of the space-occupying lesion. That means that at this point, when the dural sac stops expanding, there's going to be a rapid increase in intracranial pressure as this space-occupying lesion or hematoma continues to grow. No more cerebrospinal fluid can be pushed down the way, so if anything that can happen then is that intracranial pressure will increase sharply. And that will increase very, very dramatically, and this can result in a fairly acute loss of consciousness and acute changes to the oculomotor nerve, resulting in the altered pupillary responses. So your challenge is, can you detect small changes in Glasgow Coma Scale, small reductions in Glasgow Coma Scale, caused by relatively small increases in intracranial pressure, before this patient decompensates and suffers an acute and serious life-threatening rise in intracranial pressure. Let's think about why this idea of intracranial pressure and raised intracranial pressure is so important. Now here we have the normal situation. Here we've got the right cerebral hemisphere on this side. You can see the lateral ventricles there, the third ventricle beneath that. The left cerebral hemisphere on this side. The bone of the skull round about, forming a closed vault, of course. In the normal situation, on CT scan especially, you can see a midline between the cerebral hemispheres. And this midline here runs a symmetrical course between the cerebral hemispheres. But in a situation where there is a hematoma developing on one side, now it doesn't matter too much whether this is an extradural or a subdural hematoma, we can see it's taking up space. There is bleeding, forming a hematoma, and we can see that that is pressing in this direction. The physical presence of the space-occupying lesion generating this pressure, and we saw that punched out appearance on the post-mortem brain before. I think you can see here that the midline, which should be down the middle there, has moved across. There is midline deviation. So the brain is being compressed, there's raised intracranial pressure, and the whole brain is being distorted. Here we see another diagram, and here in dark we've got the line of the dura mater. This dark line here going down, of course, into the spinal cord is continuous, and the dura mater continues down, as we know. But we see that there's infolds of the dura, the falx here, and this infold here is called the tentorium. Now what these infolds of the dura do is they support the areas of brain. For example, the tentorium here is like taking the weight of the brain above. It is compartmentalising the brain, so it's not all just one massive structure. And we notice that this area above the tentorium is called the supratentorial area, and the area below is the infratentorial area. So the tentorium is supporting the cerebrum above, dividing the supratentorial area of the intracranial cavity, or of the cranial cavity, from the infratentorial area of the cranial cavity. It's all within the cranial cavity, but the cranial cavity is itself compartmentalised by these infolds of the dura. So here we have the cerebrum, the ventricles, third ventricle, area of the brain stem, and the area of the cerebellum. So in the infratentorial space, below the tentorium, we have the brain stem and the cerebellum. In the supratentorial space, above the tentorium here, we have the cerebrum, the cerebral hemispheres.